One of the kind of key areas that, so again, thinking about the team that I work in, we will often work with patients who've had a stroke, so stroke survivors, around changes that they can make following having had a stroke to reduce the chance of future strokes. So again, you know, even if you do face a period of ill health, there are still things that you can do to reduce kind of further deterioration or further risks in the future as well.
Okay, and what does that work involve that you do with the clients, like actually in the rehabilitation centres? What does that actually involve?
So we work with people in their own homes, so we can really get to know people, we can see their environments, we can really support them. So it could be around offering advice around supporting low mood, for example, after a stroke, or maybe if people are feeling anxious in terms of being able to return to activities, or if there's a loss of independence or impact on mobility after a stroke. So again, the different disciplines would be involved to try and support people to go back to activities that they were doing before. But we also have a dietitian, so the dietitian can advise on kind of having a balanced diet. Physiotherapists can advise on strength and balance exercises, or kind of returning to different or trying new exercises, helping people to return to swimming. And often as psychologists we work very closely with those disciplines because people may lack confidence in their abilities, or may fear having another stroke, or fear you know, pushing themselves or trying new things. So we can support somebody to do that in quite a graded way, again drawing on their resources, using strategies, so thinking about, you know, cognitive behavioural therapy, and thinking about how people appraise situations and supporting them to reach the goals that they want to.
Okay, and could you tell us a bit more about the psychological approaches that you use in your work? Do you use a range of different ones?
So there are lots of different approaches to use with people with cognitive impairment. So thinking about, if I kind of think about dementia first, so if somebody's diagnosed with memory difficulties, in the early stages, what we know is helpful is some support around using compensatory strategies, so thinking about memory strategies based on what we call cognitive rehabilitation. So that's really around getting an idea of where people's strengths are, and then using those strengths to try and compensate for the areas that they may be struggling with. So those kind of memory strategies and compensatory strategies are helpful in the earlier stages, and they can be done on either a one-to-one or a group basis. For people with a diagnosis of mild to moderate dementia, we would recommend something called cognitive stimulation therapy. So that's the non-pharmacological treatment of choice recommended by NICE. So this is the therapy that I was first involved with as an assistant psychologist 15 years ago, working with Amy Spector, and this is around basically encouraging people to be more kind of cognitively active in an implicit way. So it's not about testing people or putting people on the spot, but it's really about using people's strengths and trying to build on links with their knowledge and previous memory, and help people to engage in a fun way that actually improves quality of life and supports their cognition as well. Thinking about adjustment to diagnosis though, so thinking about dementia, thinking about stroke, one thing that's really, really important is assessing somebody's psychological, so their emotional well-being. And I do find that I use compassion-focused therapy quite a lot in my work. So this I've found particularly helpful when people are quite self-critical and blame themselves for having had a stroke, and then that's often a block in helping people to engage in rehabilitation. So people will often say with cognitive behavioural therapy that they can connect to it intellectually but not feel it emotionally. And often I found that compassion-focused therapy has been really, really helpful for patients that might describe feeling like that. So it's around having more compassion, so being kinder to oneself. And sometimes I think people assume that compassion is around, is a kind of soft and airy fairy term, but actually it's not. It's associated with courage and wisdom and strength and turning towards distress. So you're acknowledging that distress and then working with it. And one of the features of compassion focused therapy that I think is really helpful is this idea of us all having a tricky brain, but the idea that that becomes trickier when you have a stroke or a brain injury, and I think viewing the brain in that way then helps people to kind of adjust and to stop that kind of self-criticism and then kind of be able to progress with therapy. So particular strategies that I've found are helpful are things like soothing rhythm breathing exercises, using compassionate letter writing, using compassionate imagery, and as I say, I've found this particularly helpful with people presenting with high levels of kind of perfectionism, or people that have been very, very driven and perhaps led very busy working lives, always set themselves very, very high and sometimes unobtainable goals, then finding it quite hard to deal with not being able to return to the things that they were doing. So I think it's kind of around having that, being able to step back and having that kindness towards oneself, and thinking about how to soothe, thinking about how to rest, and the importance of rest being a massive part of recovery that often people are reluctant to take because people often feel that they need to keep doing in order to improve. So I think a combination of all of those approaches is really useful.
Yeah, compassion, so important.
It is, yeah.
So how might cognition actually impact issues surrounding mobility for the individuals you work with?
I suppose one key area is around safety awareness, and sometimes when we see people after a stroke, there might be changes to somebody's level of insight, their ability to reflect on what they might be struggling with, and sometimes difficulties in appraising risks. So people may take risks that they may not be safe. So thinking about patients that have previously been told not to go upstairs, for example, because of their mobility, but forget that they're not meant to do that. So then we'll try and get upstairs, often in an unsafe manner, unfortunately. There might be cases where people forget to use their walking aids because of difficulties with memory or impulsivity. So in those cases, sometimes we've had to have visuals around people's homes, almost like a stop sign or a picture of their walking aid, to remind them to use it, or trying to encourage family members to place it in front of them, because we don't want people to be at risk of falls. It's one of the major reasons that people are admitted to A&E departments. So there's lots of guidance around falls prevention. There are falls exercise classes that a lot of services run to try and reduce the risk. And again, it might be that sometimes when we're working with people with cognitive difficulties, we might be limited in terms of the safety aids that we can put into place. So if somebody's living alone, sometimes we might encourage people to use pendant alarms so that they have a button that they can press if they do fall. But unfortunately, we have had cases where people aren't able to learn how to do that, or we're not confident that people would remember to do that. So I think then that raises issues around whether people are able to be left at home safely. So I think there are lots of ways that cognition can impact on mobility. So yeah, the key ones are kind of around safety awareness and appraising that.
Mm-hmm. And do you have any examples of people you've worked with that that would be sort of clear, that the link between cognition and mobility would be particularly prominent?
Yeah, so sometimes we have an interplay. So sometimes there might be changes to mobility, so limb weakness following a stroke. Sometimes it can be more of an attentional or a cognitive impairment. So I suppose I'm thinking of somebody that we're working with at the moment who is physically able to go up and down the stairs, but the difficulty we're having is helping this gentleman remember where to place his feet, so thinking about safe foot placement, and that's more around his attentional abilities and being able to follow directions from the physiotherapist rather than a kind of a physical difficulty. So I think it's really important to be clear about whether it is around cognition or whether it's around mobility, but as I say, it does become complex because sometimes it is an interplay between the two.
I can imagine. So how is cognitive impairment measured and assessed?
Good question. So I suppose I can draw on this in terms of experience in working with patients with dementia, but also kind of stroke and brain injury. So firstly, if we think around diagnosis of dementia, it's really important to do a kind of full holistic assessment. I know we use that kind of term a lot. So I suppose what I mean is in terms of cognitive assessment being a key part of that, but also physical health assessments being done by other team members, so to try and rule out potential reversible causes of dementia, so thinking around low vitamin B12, around pseudodementia, around sort of delirium, and ruling out any infections. So that's really, really important, and getting a full history of the person's background. So if we're thinking around cognitive assessment as being part of that diagnosis of dementia, often what will happen is people will be seen in memory clinics and there will be a cognitive screen that's carried out. So the important thing is to have an assessment where you are looking at different domains of cognitive functioning. So tests that look at memory, language, visuospatial functioning, executive functioning, for example, as key areas. So often what happens in memory clinics, and I've worked in various ones, so there are some differences, but generally what would happen is you would do a cognitive screen lasting 20-25 minutes, where you would have a general assessment of those domains. If somebody has a global impairment on those across all of those domains, again, that kind of helps you to think about what support may be needed. Sometimes what we find is that there might be areas that people struggle with on more, so that's where we might use more specific assessments. So again, different memory clinics and different services will use different assessments, but my experience is often using sub-tests from kind of larger batteries, because I think when we are using cognitive assessments, we need to be thinking about the benefit of doing so, and also not putting too much demand or causing too much distress for people we're testing, but equally doing enough tests that give us the information that we need. So essentially what we want to try and answer is, does this person have a diagnosis of mild cognitive impairment? Is it a type of dementia? Does their profile of on their cognitive assessments then give us information in terms of what subtype of dementia that may be, and that will obviously inform future treatment. I think cognitive assessments in the use with people with dementia can also be helpful in terms of sometimes having a baseline and then repeating testing sort of in a year, 2 years, to just see if there have been any changes. So that can often be useful for people with mild cognitive impairment as well, where you're trying to check for any progression over time. Thinking about working with stroke survivors and elderly people that have had brain injuries, again, there will be a range of assessments that we use. So in terms of when we would and why we would use cognitive assessments, they do play a key role in our assessment of somebody's functioning. It may be if there is a block in therapy. So for example, sometimes team members will come to us and say, this person seems to want to engage in their goals, so they tell us that they want to practice this and they want to get back to this particular activity, and we set them work in between sessions, but they're not doing it and we don't know why. So it's often not a case of people not wanting to, but it may be mood, but it may also be due to cognitive difficulties, so problems with initiation, in problem solving, in being able to remember what they need to do. So cognitive assessments are really helpful to explore potential blocks in rehabilitation. It can help us think about where somebody's strengths are. So I was talking about cognitive rehabilitation and using people's skills to try and compensate for areas of difficulty. So to be able to have a profile of functioning across particular domains. It can be useful in terms of informing recommendations if people want to return to work. So we can potentially identify areas that people may struggle with. So for example, if somebody is slowed down on tests of executive functioning, if they're requiring more time to process information, if they struggle to multitask, that then gives us some useful insights into the type of role that they may need to return to in terms of work and in terms of their environment, distractions, in looking at fatigue, thinking about how to simplify tasks, so that's really, really important. A key area as well is also driving, and a lot of older people after a stroke want to return to driving to try and retain independence. So again, it might be around using cognitive assessment. So one of the batteries that can sometimes be used is the Rookwood driving battery. So sometimes we would do cognitive assessments that may highlight difficulties, for example, in executive functioning, visuospatial functioning, and then on the basis of that we would liaise with a patient's GP and maybe recommend that they are referred to a regional driving assessment centre. So that the cognitive assessments are really useful in terms of highlighting initial difficulties. I think cognitive assessments are also really useful in terms of, again, tracking improvement. So with dementia, we know that that's a progressive condition, so sometimes cognitive assessments will highlight areas of deterioration. With stroke and brain injury, we know that people can make, or that, you know, there can be improvements over several months and years. So sometimes cognitive assessments are really useful in terms of helping patients to see where they may have made improvements. So there are lots of different reasons for assessing cognitive functioning. And in terms of the assessments that we use, so we use various screens. Again, different services will use different cognitive screens. So we may use shorter ones initially, but later on in somebody's recovery after a stroke or brain injury, we have used parts of the Wechsler Memory Scale and the WACE. And again, the recommendations from that are really useful in terms of being able to support somebody to return back to activities that they previously did, or new activities that they want to take up, or again, kind of informing recommendations for employers, or thinking about people taking on voluntary roles in later life. That can be really, really important as well.
Thank you so much for your insight. Just one final question. How do you see your role developing in the future?
I think in terms of cognitive assessment, I think one thing that we could be better at is assessing or kind of having a suitable cognitive assessments to assess the general population. So especially where English might not be somebody's first language. So that seems to be an issue in memory clinics, and also several services where we maybe are not sure around the appropriateness of the test that we currently have. So I think that's an area of research and something that I'm currently doing in my academic role. In terms of the future and roles of psychologists, I think we could do more around community engagement. I think we could often involve older people a lot more in service design and thinking about the support they need. I think we need to not assume that all older people have the same needs. So somebody at 65 is likely to have very different needs and interests as, you know, compared to somebody at 80, for example. And we're not very good at co-production, so I think we need to be working more closely with older people and communities to try and support them. And I think one thing that I'm really keen on is thinking about working closely with communities, thinking about community engagement, and also thinking around intergenerational activities as well. So actually, is it that we just need to be producing services for older people together, or is it that we can think about ways of mixing different age groups, about sharing skills between younger and older people? I think that's, you know, really, really important. Yeah. And I think we all have a role to play in terms of, you know, raising awareness of difficulties with kind of cognition and mental health, and reducing stigma, and supporting older people to you know, go to memory clinics if they are struggling with memory, speaking to their GPs, and, you know, demystifying myths around assessment and diagnosis being scary, but actually it's really, really important to get that early diagnosis, to get assessments completed at an early stage, so that we're then able to support people earlier on and hopefully, you know, delay some of the progression of difficulties, and also to support carers. So we know that a lot of older people care for family members and loved ones, so just to ensure that we are supporting the needs of older people.
Great, thank you so much. It's been really interesting and so important, I think. So
thank you.
Yeah, thank you,
Thank you for having me.